Good
Yeah.
afternoon, everybody. On behalf of General Practice Association Greter Bombay and Jaslok, I welcome you all on the occasion of 296 webinar. And our today's moderator is a very senior practitioner from Sain as well as Ghatkopar. May I now request Dr. Atul Doshi to take care of the proceedings. Over to Dr. Atul Doshi.
Thank you, sir, for your kind words. And we have a good Mrs. Lina Ben Bhagat, who is going to take forward the proceeding. She is a doing family practice since 35 years and as running a center coordinator at Borivali for 15 years. She is an active member in GPA and active participant in many webinars and seminars. Yes, madam, you can continue, madam.
Hello, friends. So today our speaker is Dr. Nikesh Jain. He's a DN. He has done DNB cardiology, FESC, and FSCAI. He is a fellow of Structural Heart Disease Germany. He's a consultant interventional cardiologist excelling in the field of interventional and non-interventional cardiology with 10 years of experience in the field of cardiology. He has cleared DNB medicine and DNB cardiology from Jaslok Hospital, first attempt. His current affiliations are Jaslok Hospital, Breach Candy Hospital, Wokhart Hospital, Safety, Bhatia, Global Hospital, and Messina Hospital. He has contributed to various textbooks like P.J. Mehta's Clinical and Emergency Medicine, and he has written chapters on complex coronary issues on the left main, chronic total occlusion, constrictive pericarditis, and anomalous coronary artery interventions. He has published many articles in peer-reviewed journals on topics like CFO, FFR, CTEPH, stent thrombosis. He has been awarded the Amar Gandhi Award for Best Resident at Jaslok Hospital, and as a tower team at Jaslok Hospital, he has performed highest number of towers in Western India. His special interest is in complex coronary interventions, tower and other SHD, heart failure, and heart transplant workup. We now invite him to give his talk.
So thank you very much for your kind introduction. So this is my second talk in subsequent session. So today's topic is management of valvular heart disease. So valvular heart disease per se is a very vast topic to cover in one talk. It may require like 8 to 10 lectures or so. But in today's talk, I'll just brief you regarding some basic fundamentals of valvular heart disease and just how to approach a basic case of a suspicion of valvular heart disease. So as you know, the valves of the heart, there are two pairs of valves and they maintain a unidirectional flow of the blood and prevent its regurgitation in the opposite direction. Okay, so there are two pairs of valves. Okay, right-sided tricuspid valve, which has three cusps, which the mitral valve and the tricuspid valve are called as atrioventricular valves, which is AV, which I've written in shortcut. Basically, this guide the blood flow from atrium to the ventricles. The mitral valve will guide the blood flow from left atrium to left ventricle, and tricuspid valve will guide the blood flow from right atrium to right ventricle. Semilunar valves, which are aortic and pulmonary, they will guide the blood flow, okay, from left ventricle to aorta in case of aortic valve, and from right ventricle to the pulmonary artery in case of pulmonary valves. Okay, so these valve structures are basically just folds of endocardium. Okay, what is called as endothelium, which are present in the inner lining of the blood vessels, and the intervening layer is just a layer of fibrous tissue. Okay, so basically they will open as a gateway mechanism like in any structural pipe valves we can see to maintain a unidirectional blood flow. That is an important mechanism of these valves. So this is a schematic diagram if you understand this. So basically the blood comes from the legs through inferior vena cava, from all the abdominal organs, legs, through head, arms to the superior vena cava. They will go into the right atrium. They will go into through the tricuspid valve, which is act as a gateway. Okay, so during the diastole, the blood will go from right atrium to right ventricle, and then the blood will flow to the pulmonary artery and to the pulmonary arteries and branches. From the pulmonary arteries, it will go to the pulmonary veins, and from there, from the pulmonary veins, the blood will enter to the left atrium, and from the left atrium, it will come into the left ventricle, and then from left ventricle to the aorta that provides oxygenated blood to brain, limbs, abdominal organs, kidney, liver, everything. Okay, so this is a sequential flow of blood which is important, and this is all gated by all these four valves. Dysfunction in any of the valves will disturb the hemodynamics and the blood flow mechanism to all the organs. Okay, so this sequence is important, and any disturbance, as I told you, in stenotic or regurgitation will cause a problem. So basically there are four valves. In mitral valve, okay, there are many primary diseases which will come to it later. So the most common involvement is primary valvular pathology. Similarly for aortic. So the mitral and aortic pathologies are more common, and many of them involve the valve structure per se. But tricuspid valve, which acts as a gateway from right atrium to right ventricle, okay, tricuspid valve involvement, specifically in adult age group, it is usually secondary to left-sided pathologies. Means if there is a mitral stenosis, if there is a severe LV dysfunction, so in turn, in a back pressure changes, okay, it will involve the tricuspid valve, but not the primary pathology per se of the tricuspid valve. Okay, pulmonary is usually in congenital anomalies. It's more of an association as a syndrome. You will not come across pulmonary valve pathologies in adult population quite often. So pathology is simple. Either it can be stenotic or it can be regurgitation. Okay, stenosis means the orifice of the mitral valve, which allows the blood that gets choked up, that gets stenosed. Regurgitation means it will not allow the unidirectional flow. The valve remains open during systole. So what happens is, in this right atrium and right ventricle and this left atrium and left ventricle, the blood will flow from respective chambers into the LV and RV during diastole. Blood will flow from RV and LV into the pulmonary artery and aorta respectively into the systole. Okay, so in systole what happens is this mitral valve and tricuspid valve will be closed. So what happens in regurgitation, even in systole, the mitral valve and the tricuspid valve is open. So blood will go into the aorta and blood will go into the left atrium also. That is a mechanism of regurgitation. Okay. In stenosis, during the diastole, which the blood has to flow from left atrium to left ventricle, there is a stenosis. So there is an impingement of flow over here. So all the blood from the left atrium will not enter into the LV. That is called a stenosis because of the constriction. Okay, this is the basic pathological mechanisms of this valvular disorders. And the hemodynamic consequences, I will tell it to you later. But just remember this diagram, this unidirectional flow of blood from SVC, IVC, RA, RV, PA, pulmonary veins, LA, LV, and aorta. Just remember this in your mind because all the hemodynamic consequences will be all related to that. Just for a simple example, if the mitral valve is stenosed, so there is impingement of blood flow here. So blood and the pressure inside the LA will keep on increasing. This pressure will get transferred to the pulmonary veins and in turn to the pulmonary arteries. Okay, so what will happen? The PA pressure, the pressure inside the lungs will increase. That is a mechanism of dyspnea. Okay. In turn, there will be a lot of pressure inside the RV to eject blood into the pulmonary artery. So there will be some TR. Okay. So you select one valve and you keep on having some back pressure hemodynamic consequences and you will understand the symptoms. Okay. This is a basic phenomenon. So whenever a patient is having suspicion of valvular heart disease, so how do you evaluate? Most important is the clinical features are the most important thing. Just don't go by the symptoms. Clinical features means we could talk about some various signs also. Okay, like murmurs, loud P2, depending on the severity of valve stenosis, we decide for the surgical part or the management part. Clinical features include symptoms and signs, which include murmurs, quality of heart sounds, and additional sounds. ECG, 2D echo, X-ray, and MRI in some cases. So in culmination with all these findings on each specific modality, we decide whether the patient is for medical management or surgical management. Clinical manifestations. So symptoms are proportionate to the severity of disease, means mild disease will not have much symptoms or only mild symptoms. Moderate to severe category will have severe symptoms. Long latent period. So all the valvular heart diseases, unless there is an acute phenomenon, are slowly progressive. The natural history is very long, like 5 years, 10 years, or 15 years. Means the start of onset of pathology of a certain valve to its severe progression is very long. That is called as natural history. Okay. So until it reaches a moderate to severe category, then only patients become symptomatic. Otherwise, most patients, sometimes even in severe valvular cases, they are asymptomatic. Once they show signs of any severity, be it symptom-wise or echocardiography-wise that I'll discuss later, early intervention is recommended because these valvular cases, once the LV is burnt out or the RV is burnt out, there is a severe PA pressure, pulmonary hypertension which has developed. Operating in such cases is riskier and even the long-term outcomes are not good. Okay. Severity assessment, okay, when we do it on echo specifically, it can vary depending on variables like heart rate, blood pressure, anemia, fever. So whenever we do a 2D echo for such valvular patient, we make sure that all these variables are under control. Heart rate is optimum under 70-80, blood pressure is normal, there is no anemia, no any secondary causes like hyperthyroidosis or thyrotoxicosis or any fever that increase the gradient across, because all these variables will affect the gradient measurement across the valve. Okay. So long latent period, symptoms proportionate to the severity of disease, and once severe or any early signs of decompensation, subject the patients for early intervention. So coming to clinical manifestations. So clinical manifestations are similar to any cardiac cardinal symptoms, what we call dyspnea, means breathlessness on exertion. These are typically common in regurgitant lesions like MR and AR. Okay, like mitral regurgitation, aortic regurgitation, and stenotic lesions like mitral stenosis. Palpitations. Palpitations are more common with regurgitation lesions like mitral regurgitation and aortic regurgitation. Chest pain. Chest pain is more common with aortic stenosis because it causes LVH. Chest pain may be common in mitral stenosis as well because of RV hypertrophy. As I told you, in mitral stenosis, when there is a blockage, when there is stenotic of valves, all the back pressure changes will keep on developing and the pulmonary hypertension will develop and in turn RV hypertrophy. So that is the cause of chest pain in mitral stenosis. Fatigue. So fatigue is a common symptom for TR. Okay, like fatigue, decreased exercise capacity. Okay, because in TR what will happen is, as I just remember the diagram, the blood from the RV, instead of going into the pulmonary artery, it will go again into the RA. So there will be no forward flow. Okay. And in patients with all these secondary valvular lesions like MR, MS, if they develop severe pulmonary hypertension, they also cause fatigue. Okay. Because there will be no forward flow to the LV. Okay. Still syncope. Syncope develops whenever there is a decreased blood supply to the brain. Okay. Whenever there is a compromised blood supply. So LV will push the blood into the aorta and to the brain. So in aortic stenosis, as there is a decreased blood supply to the brain because of severe stenosis, patients can have syncope. Okay. Even in severe pulmonary hypertension, because in severe pulmonary hypertension, there is a lot of resistance from RV to push the blood into the LA. Okay. So there will be LV output which is decreased. Okay. So that is why in these two cases, there will be syncope. So each symptom, okay, will decide regarding a guiding investigations and your suspicion of which valve are you suspecting. Okay. So dyspnea palpitations more for regurgitant lesions, chest pain more for aortic stenosis and mitral stenosis, fatigue more for regurgitant lesion like TR, and syncope for aortic stenosis and severe PH. Signs will be classical, loud P2 if the pulmonary hypertension has developed, you will see a loud P2. The murmur, the location of murmur, okay, will depend on the which valve is involved. If you're hearing a loud systolic murmur at the apex, then it is more likely mitral regurgitation. If you're hearing a diastolic murmur in the parasternal area, then it is more of a aortic regurgitation. Okay, aortic stenosis will give you a systolic murmur right at that right parasternal area or in the pre-urbs area, what we call the third left parasternal area. So this, according to the location of murmur, we decide the which valve is involved. There can be mixed pathologies also. Mitral stenosis, mitral regurgitation is very common. Aortic stenosis, aortic regurgitation is very common. Okay. So there can be multiple murmurs or multiple sounds which can be there, and we have to decide which is more severe. So that just requires practice. So in generalized term, left-sided valve pathologies means mitral valve and aortic valve will give rise to dyspnea, chest pain and palpitations. Right-sided valve pathologies will give fatigue, edema feet, and anasarca. Because as I told you, all the blood from the RV will be pushed into the RA, and RA is connected to SVC and IVC. So all the back pressure will go into the SVC and IVC and into the liver, edema feet, legs, okay, sometimes face swelling also. So this is the general dictum for the symptomatology, okay. Coming to other evaluation part, which is ECG. ECG may not help you in valvular diagnosis, but it will help you regarding the severity of chamber involved. So basically, if it's a mitral stenosis, there will be left atrial enlargement on ECG. Okay, if there is a severe TR, RA-RV is dilated, there will be signs of right atrial enlargement. LVH, if it's present, it will suggest that aortic stenosis is turning out to be severe. Okay, RVH, if there is a severe pulmonary hypertension, then you will find signs of RVH on ECG. So this will just tell you indirectly regarding the long-standing valvular heart disease which was present and the effects on the heart, but not exactly the severity. 2D echo is the most important diagnosis. That will tell you about LVF, the valve area. There are various methods that we use during the 2D echo measurement. There are some equations which we follow. Quantifying regurgitation, there must be 4 or 5 parameters on echo to quantify whether the regurgitation is mild, moderate, or severe. Pulmonary hypertension, RV function is most important. As I told you, once there is a development of severe pulmonary hypertension, RV dysfunction, those patients are worst case for operability. Okay, and they don't, even if their surgery is successful, they don't fare well, good enough in long-term recovery option. Okay, so before the patients develop pulmonary hypertension or RV dysfunction, that is the time for the surgery, an optimal candidate. And as I told you, even 2D echo is quite interobservable variability. Get 2D echo in good centers with a good cardiologist, because small centers will not give you exact parameters. You will find one lab reporting mild, moderate aortic stenosis, and if you do it with a good machine with a good hands, then it turns out to be severe. Okay, so definitely get an echo done with a good operator. Once I had got a patient labeled as asthma, and when I did an echo which was labeled mild AS outside, I diagnosed to have severe aortic stenosis. So definitely the operator, it's very important with good echo machine. Chest X-ray will just tell you similar to the ECG regarding the chamber enlargement and pulmonary edema. MRI is sometimes useful, specifically in regurgitant lesions, to quantify the regurgitation amount. If sometimes we want to calculate the LV volumes exactly, if the patient is being worked up for DVR or a very high risk valve surgery, how much will the patient benefit? So sometimes MRI is useful for exact quantification of all the parameters, but not always. I'll discuss about two valves, mitral stenosis and aortic stenosis in brief, and some advanced valvular surgeries that we are doing. Pulmonary and tricuspid, as I told you, tricuspid is more of a secondary pathology. Secondary to left ventricular pathology, the tricuspid valve is usually involved in adults. Yes, there are definitely important tricuspid pathologies, but we can take it at some other time in with some other talk with other valvular heart disease. So mitral stenosis. So per se, rheumatic heart disease was very common around a decade ago or maybe 2 decades ago. But right now, in the future also, you will not get rheumatic heart disease cases quite common now. It is already getting uncommon now. Okay. So now, previously, the rheumatic heart disease was the most common cause of mitral stenosis, but now mitral annular calcification, specifically with increasing aging population, that is the most common cause now. Okay. Mitral annular calcification means the mitral annulus, the mitral leaflets are attached to the annulus of the LV. So there is like we have calcification in the coronary arteries, even the valve gets calcified. It starts at the annulus and keeps on spreading inside the valve tissue. With aging population, this is becoming more and more common now. And this is a very difficult subset to treat. Most surgeons, they don't touch also, they just manage on medications. Uncommon causes are carcinoid, connective tissue disorders. Previously, we used to use these drugs for methysergid, okay, and congenital MS. But for now, for a discussion purpose, yes, we can still see rheumatic heart disease cases and MAC in elderly population. So basically, understand this hemodynamic part. There will be obstruction to the LA emptying. So LV will not get enough blood. There will be increased LA pressure. And as I told you, behind the LA comes pulmonary veins. So there will be increase in pulmonary venous pressure. So there will be pulmonary edema. Okay. If it's not controlled at this stage, the pressure gets transmitted to the pulmonary artery, and then there will be pressure RV overload. Okay, with increasing LA size, okay, there will be a increased risk of atrial fibrillation and arrhythmias. So whenever there is an increased pulmonary venous pressure, there will be dyspnea, arrhythmias because of atrial fibrillation, and RV overload will cause you chest pain. So this is how the symptoms are explained. Okay. So hemodynamic goals in mitral stenosis. So since the LV is not getting blood, we have to keep adequate amount of volume, but not to overload the patients. Heart rate should be optimum, not very high also. So because as I told you, the blood from mitral LA to LV comes during diastole. So if the heart rate is very fast, okay, it will not, the diastolic time will decrease. So dyspnea will increase. That is the optimal heart rate control is important. Okay. Afterload that has to be maintained, though it may not useful in mitral stenosis cases. PVR has to be low, so avoid acidosis, hypoxia. Okay. So severity of MS, basically once is by symptoms. Progressive dyspnea, yes, definitely if the patient has class 3 or class 4 symptoms, definitely patient requires management. And mitral valve area, which is normally 3 to 4 centimeters square. If you find on 2D echo report that if it is less than 1, definitely it categorizes into severe mitral stenosis. Moderate to severe pH, though not an indicator of severity, but indicates it's a long-standing MS, and it will tell you the prognosis of the patient regarding post-op course and the complete recovery. Because sometimes this pH becomes irreversible if it's too long-standing. Okay, so definitely treat in early stages below the mild or moderate pH cases, not in severe pH. Okay, associated lesions, MR or AS, that also decides our management. So if the MS is moderate and MR is moderate, so both moderate lesions will give you more symptoms. So even in moderate cases, you have to operate the patient. Okay, if the MS and AS both are there, so even AS will cause a lot of LV volume overload, LV hypertrophy, but there is no blood inside the LV because of MS, severe MS. So in such cases, in mixed valvular lesions, if both the valvular lesions are moderate, sometimes you operate the patient. So valvular heart disease, as I told you in the first slide, it's a variation. Okay, it's a wide spectrum of presentation of symptoms. So sometimes case to case scenario, we decide our management. Management of mitral stenosis, as I told you, there is pulmonary venous overload and venous hypertension. So diuretics, you will find in all my slides, diuretics remain the mainstay for valvular heart disease because there is no medical correction is possible for all these valvular problems. It has to be surgical. It has to be repaired anatomically. Okay. So definitely diuretics are the mainstay of therapy for mitral stenosis. If there is any development of arrhythmias, okay, management of atrial fibrillation. Many of mitral stenosis patients, they don't convert to sinus rhythm. Okay, they specifically if the LA size is very large, okay, then they go into chronic atrial fibrillation. So we can manage with digoxin, beta blockers, and dilzam. Okay, digoxin is widely used in valvular heart disease, even if the EF is normal. Okay, because it acts as a forward pump for the heart. Okay. If the patients with mitral stenosis and atrial fibrillation, or even without atrial fibrillation, can develop a stroke for mitral stenosis because there is a lot of stagnation of blood, specifically if the LA is large. So in such patients, specifically in mitral stenosis rheumatic patients, there is no role for NOACs. So give only warfarin or acetylene for stroke in mitral stenosis rheumatic origin. Okay. So see, medical management is stabilized, patient PA pressure is getting under control, and valve area is less than 1. So there are two options now. Balloon mitral valvotomy is an age-old procedure. Okay, so we decide what we call as Wilkins score on 2D echo. If it's less than 8 or so, we send the patients for balloon mitral valvotomy. Basically, it takes into account the thickness of the valve, the subvalvular structures, the calcium, and depending on that, there is a Wilkins score which we calculate. So if the patient is not a candidate for balloon mitral valvotomy, which is done to the leg, and what we do is we pass a balloon across the mitral valve and we crack open the stenosis. It basically creates a crack in one of the leaflet, the posterior leaflet, and the orifice becomes not normal, but the area almost doubles. That is a target criteria. Definitely it can have restenosis, but at least we can avoid a replacement at an early age. The valve replacement the delay the better. Okay, because we should not have a redo surgery. Even if it's a metallic valve, it will be lifelong. But for bioprosthetic, delay the surgery, that will be better. Mitral valve replacement, definitely if the patient is not a candidate for mitral valvulotomy. So there comes the two options, metallic versus bioprosthetic. That is true for aortic as well. So the dictum is, if the patient age is less than 55, we go for metallic valves because the durability of metallic valve is lifelong, provided the patient takes warfarin. Okay, because we have to maintain the INR of around 2.5, specifically in mitral valve cases. If the patient age is more than 60, okay, patients go for bioprosthetic valves, that is tissue valve. That doesn't require warfarin. The half-life of the life expectancy of bioprosthetic, the company claim around 15 years. Okay. Now there is a Resilia valve, which they are claiming around 20-25 years. Okay, so that also will be a good lifelong in relatively younger patients, also like 50, if there is any contraindication to anticoagulation. 55 to 60 is a borderline age group. Depending on the risk profile of the patient, we can subject the patient to bioprosthetic valve if the patient is at a very high risk of bleeding. Okay, so management, diuretics, digoxin, atrial fibrillation management with beta blockers and dilsem. If the patient has a stroke, warfarin, no NOACs in RHD rheumatic heart cases. If the patient is eligible, balloon mitral valvotomy, otherwise valve replacement. MAC, as I told you, it is commonly seen in elderly population, but it's difficult to manage. Even surgeons can touch the severe calcification which is observed sometimes. In selected cases, there are cases which we have done is transcatheter mitral valve replacement in cases of MAC without an open heart surgery through the groin. But it requires a lot of patient selection. There are specific anatomical criteria which we can select such patients, so not all patients. Otherwise, these patients can be just managed on diuretics and symptomatic management. Nothing can be done about such patients. Coming to the mitral regurgitation, means there is a leakage from left ventricle to left atrium during systole, from which the blood has to go from aorta to the aorta, but instead of that, most of the blood is going to the LA also again. So common causes being rheumatic, mitral valve prolapse, and MAC again. Secondary causes are important: cardiomyopathy, ischemic LV dysfunction, ischemic acute MR. So you will commonly find that the patient who has cardiomyopathy or ischemic LV dysfunction whose EF is 25-30, those echo also you must be seeing that those are reporting moderate MR, severe MR. So that is not because of valve pathology. That is because the LV size has increased, okay, and in turn the mitral annulus has increased. So there is a gap in between the mitral leaflets. Like if you take a door and if you widen the space of the door space, so door will not close completely. Okay, it will have some passage of air in between. That is called as this mitral annular dilatation. So treatment is medical management for secondary causes most often. Sometimes patients, if they're undergoing any CABG surgery, they're trying to repair or they're trying to shorten the annulus with a mitral ring. Uncommon are carcinoid collagen disorders, carcinoid. Okay. So coming to the hemodynamics part, so there is a leakage of blood flow from LV to LA during systole because the blood has to completely go into the aorta. So again, with mitral stenosis, there is an increase in LA volume and pressure. LV filling is increasing, okay, because again, a large amount of blood is coming back into the LV also. Okay, there is an increased systolic volume and blood is injected into the aorta. But in this, what is happening is the LV starts dilating at some point. LV has to take more amount of work stress because of increased amount of blood. So there is left atrial enlargement, increased pulmonary pressures and pulmonary edema again. Okay, so if you just remember the diagram, whichever valve you select, just keep on calculating the back pressure changes, and in terms of regurgitation, an extra amount of blood enters the LV, okay, because of regurgitation blood plus the amount which was already going into the LV. So there's a lot of LV volume overload, what we call. In mitral stenosis, there is LA pressure overload, but in regurgitation, there is extra amount also, and extra amount of blood to be ejected also. So this is simple. In normal systole, the left atrium, the mitral valve remains closed. In mitral regurgitation, the valve remains open. So there are two phenomena in this. Most commonly, you will come across this chronic MR. Okay. So in chronic MR, gradually the LA keeps on dilating. In acute MR, which I'll come across specifically, the most common cause is in mitral valve prolapse. Sometimes there are supporting structures, what you call as chordae. The chordae gets torn and the valve becomes flail. Okay, it becomes extremely floppy. It doesn't coapt. So in acute MR, patients will become acutely breathless, but the LA pressure will be LA pressure will be high, but the size will be normal on echo. That is how we judge whether the MR is relatively acute or subacute or it's in a chronic. Acute MR requires immediate intervention, surgical intervention. So preload we need to adjust depending on the pulmonary edema status. Avoid bradycardia. In bradycardia, what will happen? Okay, the duration of systole will increase. Okay, so if bradycardia increases, the amount of systolic period increases, duration of systole increases, and the leakage of blood flow also will increase. Okay, afterload, meaning the tone of the aorta. Okay, so if afterload reduction is helpful, that is why we prescribe ACE inhibitors. Afterload means if there is a blood flow through a pipe, okay, through another pipe, and there is a gateway. If there is a lot of pressure in the opposite side, there will be resistance to the flow of water into the opposite side. Similarly, this is called as afterload. So if the afterload, if the pressure inside the aorta is high, there will be difficulty in LV to eject the blood. And as simple as that. Okay. So treatment, as I told you, diuretics will be in all my slides. Digoxin will be almost in all my slides. ACRBs is useful in regurgitant lesions to reduce the afterload, to reduce the pressure in the aorta, so that the LV can eject the blood in the aorta successfully, okay, and more efficiently rather than going into the LA. Beta blockers, yes, if there is patient is in heart failure, there is LV dysfunction, but avoid too much of bradycardia. Optimal heart rate of 70-80 is important. Stroke, if the patient has atrial fibrillation, even without atrial fibrillation, patient can have stroke, specifically if rheumatic. And as I told you, warfarin is important. So rheumatic MR requires mitral valve replacement. It cannot be repaired. In mitral valve prolapse means the valve is floppy, what we call. Okay, it excessively bulges into the LA. Okay, like if the valve is closing like this, in mitral valve prolapse, it will close like this, like a bump. This is called as mitral valve prolapse. Okay, so in mitral valve prolapse, if there is a severe MR, repair is feasible. Okay, the anatomy is not so disturbed as in rheumatic. Ischemic acute MR, surgical replacement is preferred unless the patient is very unstable. Okay, and couple of cases we have done is like doing a plasty and a mitra clip in my last class which I have written. But generalized as a rule, replacement is done. Some cases repair surgeon can do repair also if the anatomy is not disturbed much. Secondary causes of MR, as I told you, cardiomyopathy, ischemic LV dysfunction, MAC, only medical management is helpful. Surgery has not proven to have any additional benefits. If the patient is going for CABG surgery or any valve surgery, yes, then they correct the annulus with a mitral ring or so. Mitra clip is a newer procedure done for high-risk surgical cases, in cases of mitral valve prolapse, or in selected cases of acute ischemic MR. Okay, and it is an indication for secondary MR, secondary to cardiomyopathy or ischemic origin. Okay, when the annulus is dilated to optimize the coapt of the valve. I'll come to that mitra clip later on. I'll have some slides. Aortic stenosis is the most common pathology now. Because of aging population, the most common cause is degenerative. As I told you, there is a calcium deposition in the valves. There is a calcium deposition in the aortic valve as well, which is an aging process. Bicuspid valve is also common pathology, means instead of 3 leaflets, there are 2 leaflets. Most of the times, bicuspid will give you faster degeneration of the valves and stenosis or regurgitation. Rheumatic is uncommon. You will not find many cases of rheumatic. If it's a rheumatic, you will also find mitral pathology. Isolated aortic stenosis, rheumatic is very uncommon. And congenital that we are not taking into consideration in this talk. So whenever there is an aortic stenosis, there will be obstruction to the LV ejection. There will be a lot of pressure gradient and pressure overload to the LV, which causes hypertrophy. So when there is an LV hypertrophy, the pressure will get transferred to the LA, pulmonary veins, and dyspnea will develop. Syncope, because there is an obstruction to the LV, so the blood supply to the brain, kidney, and other organs gets compromised. In very late stages, sometimes you will find the patient's LVEF has also started dropping because patient LV cannot take such a high overload, high pressure overload. The LV gives away. Okay. So this is a classical example of bicuspid aortic valve, 1, 2, and 3 leaflets, and versus in bicuspid, 2 leaflets are fused, and there are only 2 leaflets, functionally 2 leaflets. Okay, this is a very common pathology in Indian subsets. In fact, many a times when we work up for aortic stenosis, we find that all the patients had bicuspid aortic valve, either complete or partial. So maintain the preload because the LV itself cavity is very small. Avoid extremes of heart rate because, as I told you, LV will not get time to eject the blood into the aorta in case of aortic stenosis. So very high heart rate is not recommended. Avoid dehydration in such patients. Don't give nitrates. That will decrease the preload. Okay, so in aortic stenosis, no diuretics unless the patient is in failure, and no nitrates. So severity. So aortic valve stenosis is defined as aortic valve area of less than 1 centimeter square and mean gradient of more than 40. You will get all these values on a 2D echo report. An aortic jet velocity of more than 4. There are caveats. If the heart pumping is down, if the LVF is less than 40, this mean gradient may not be 40. It may be lower. But if you get a valve area of less than 1, then there are steps to evaluate whether it's a true aortic stenosis or a false. Okay. Similarly, in patients with very small LV cavity, these gradients always may not come high. So we go by symptom severity. We go for more additional parameters on echo. So diuretics, as I told you, it will be in all my slides. It's given only if the patient is in LVF for pulmonary hypertension. Optimal dose of diuretics, but not excessive diuretics. Otherwise, patient will have a lot of symptoms. Aortic valve replacement is the only modality of treatment. No repair, nothing. TAVR, that is transcatheter aortic valve replacement, that we are doing day in and day out now for moderate to high risk surgical cases for whom surgery cannot be offered. Coming to the aortic regurgitation, as I told you, rheumatic is quite uncommon. Even if it is there, it will be more commonly associated with mitral valve pathologies. Similarly, for aortic stenosis, bicuspid is another common pathology which is there. Degenerative, similar to that aortic stenosis, even calcification can restrict the opening of the aortic valve. So bicuspid and degenerative are the most common causes that you will come across in adult population. Uncommon causes are connective tissue disorders, which can have SLE, Takayasu, or ankylosing spondylitis. Aortic root. So when the aortic root gets dilated, the valve also will get stretched and that will cause leakage. Okay. So aortic root pathologies are common in connective tissue disorders like Takayasu's, rheumatoid, ankylosing spondylitis, uncontrolled hypertension. This is also an uncommon cause. In many hypertensive patients, you will find the aortic root is very dilated. Though it doesn't cause severe AR, but it will cause mild to moderate AR. Okay. So what is happening is blood flow from the aorta, which has to go forward, but in diastole, there is no coaptation of the aortic valve, which acts as a guide to prevent leakage of blood. So in diastole, the valve remains open and there is leakage of blood from aorta to the LV in the diastole. So there is a lot of LV volume and LV pressure. In turn, what will happen? LA pressure will increase, pulmonary venous pressure will increase, and pulmonary edema. LV volume and pressure both are overload are present, so there will be increased wall tension and produces hypertrophy of the LV. And in regurgitant lesions, mind you, both in MR and AR, once the LV starts failing, that is a very bad prognosis. In regurgitant lesions, LVF has to be supranormal, like 60, 65, or 70. Even if the aortic regurgitation, if the cardiologist has mentioned EF of 55, which is normal for other individuals, it is a bad sign. That means LVA started to fall. Okay. So keep in mind this value LVF of 60, 65, not lower than that. So in concentric hypertrophy, which is present in aortic stenosis, in eccentric, what we call, there is an LV dilatation also and hypertrophy also. So regurgitant lesions don't fare very well, be it MR or AR. Similarly to MR, in acute AR, there will be rapid increase in LVEDP as well because the LV will fall suddenly. In chronic, the LV gets time, but in acute, LV doesn't get time. There are very uncommon causes like infective endocarditis, which has caused an acute to subacute AR. Otherwise, acute AR is quite uncommon. So management remains the same: diuretics, ACE inhibitors, ARBs, because it will decrease the afterload and it will allow the LV to pump more blood into the aorta. beta blockers, arrhythmia control. Aortic valve replacement is the only modality of treatment for AR. Tower has not been indicated to do transcatheter replacement for AR. Okay, because there are technical issues in that valve can get dislodged. Though in some AR cases, in select cases, we have done tower in couple of cases. Okay, there's a different type of valve also which is available, and there are some technical aspects which can be done. So this is just chart which I want to emphasize. So as I told you in my first few slides, there is a long latent period, okay, for valvular heart disease, from mild to moderate to severe. But once the severity starts increasing, we can see this dip. There is a drastic dip in the survival rate, in the symptomatology and the severity of symptoms. And tackling at this late stages will not give you benefit. It will increase the mortality of the surgery also and the post-op recovery also. So we have to calculate the right time, correlate with echo symptoms. Echo will tell you whether the LV is failing. What are the severity of symptoms which are increasing PA pressure, LV size, LA size means the severity is long standing. Okay. And accordingly time the patient for early surgery. Because what happens is patients may get benefits from medical management and they keep on delaying the surgery because it is not an acute medical emergency. But what happens is then the prognosis becomes bad. The recovery becomes bad. So timing of intervention, mild to moderate cases, regular follow-up for every 4 to 6 months. Severe cases also can be asymptomatic. But if on 2D echo, if you find the severity is very severe to very severe category, regurgitation area is very high, the valve area is very low, subject the patient for surgery even if the patients are fairly asymptomatic. And as I told you, moderate dual lesions, 2 lesions with moderate category, severe asymptomatic cases, subtle symptoms if the PA pressure is high. We sometimes calculate LV dimensions, LV size, strain. We all this do this to guide the timing of intervention. And as I told you, stenotic lesions fare better than regurgitant lesions. Regurgitant lesions, if even if the slightest sign of LV falling or if the LV dilates, subject the patient for early surgery. Just a brief word about the prosthetic valves. So surgery has been done. The patient has been selected metallic or bioprosthetic depending on the age. As I told you, less than age 55 is metallic, more than 60 is bioprosthetic, 55 to 60 is gray zone. Metallic valves always warfarin or acetylene has to be given, no NOACs. INR has to be maintained between 2 to 3. If it's a dual valve replacement, up to 3. Mitral valve up to 2.5. If the patient skips or if the INR is not maintained properly, patients can come with valve thrombosis. That means there is a thrombosis, develop of thrombus on the metallic valve. That is a dire medical emergency. Patient can lose his life. And regular echo for prostatic valve dysfunction as well. So acute metallic valve dysfunction, if the INR is not maintained, there will be valve thrombosis. Thrombolysis is the modality of choice. And if the patient doesn't respond to thrombolysis, gradients don't come to normal, valve redo surgery, that is redo valve replacement. Chronic metallic valve dysfunction, that is an acute metallic valve dysfunction. So there is a gradual development of what we call as PANS. PANS means a progressive membranous fibrous growth on the metallic valves. This is a gradual development. Some prostatic valve cases you will find there is a gradual increase in gradient. So when it comes to severe, then the patient will require valve replacement. Bioprosthetic valve dysfunction, there is a wear and tear of the tissue. Okay, and then for that patients, those patients are elderly because we select such valves in elderly patients. So definitely for those patients, we have to opt for transcatheter therapies because most patients will be elderly and they do not undergo redo open surgery unless the patient is fit for that. Infective endocarditis. Okay, so infective endocarditis, most likely there will be predisposing factors like mitral valve prolapse, bicuspid aortic valve, rheumatic heart disease, prostatic valves. Okay, and there will be recent procedures. Dental surgery, GI surgery are the most common predisposing surgeries. Aortic regurgitation, infective endocarditis means there will be development of infective mass, infective vegetation, what we call, on the valves, causing regurgitation. Okay. So 4 to 8 weeks of antibiotics are required and valve replacement in majority. There is no rule for valve repair. Okay, there will be always valve replacement. In some cases, what happens is there is just a mild to moderate leakage. With antibiotics, the vegetations heal and the regurgitation also remains stable in few cases. In those cases, yes, we can wait and watch without subjecting the patient for surgery. Okay. Antibiotic prophylaxis. So patients who have already had valve surgeries, prosthetic heart valves, who have predisposing valve disorders, mitral stenosis, aortic stenosis, for those patients who are undergoing surgery, dental procedures, GI procedures, always give antibiotic prophylaxis, IV, not tablet. Okay. The guideline is 1 hour before the procedure, 6 hours after the procedure. Okay. So antibiotic prophylaxis is recommended for all such patients. Coming some advanced modalities of treatment, tower is not a new to you all now. Many people have given talks on tower. This is a very good feasible option. Previously, it was used to be done for only for high risk patients, but now we are doing for intermediate risk of the patients also, considering the longevity of the TAVI. Yes, definitely there are anatomical subsets which needs to consider. Proper case selection is important for all such patients. So basically, it is done through a leg, like we do an angioplasty, though the diameter of the tube is more. Okay, it is done to the groin. This is how we introduce the valve. First we dilate with the balloon and then we insert a valve. Okay, all done under fluoroscopy, local anesthesia with mild sedation. We don't give general anesthesia, no intubation is required. So this is commonly available, which was there from before, which is an evolute valve. There are much more modifications of this evolute valve which has come up now. Okay, so this is the flower shaped thing, which is an evolute valve, tower valve, which is implanted. And this is another valve which is called as my valve, which is an Indian made valve, but we're doing very good with very good results. Okay. This is how the deployed my valve looks across the aortic valve. This is another case of carcinoid disease with severe TR. This is a case of Dr. Nihar Mehta. You must be knowing him very well. So this was his patient with carcinoid disease. This is one of the pathology of primary TR. So this carcinoid disease ate away the tricuspid valve. You can see this gap in on the right side of the screen. These valve structures are not coapting. There is a free flow of blood from RV to the RA. So this patient was in refractory heart failure, persistent ascites, anasarca. Okay. So this we had to do what we call as a trick valve. Okay. So this patient valve was implanted in SVC and IVC. Okay. So this is a schematic diagrammatic representation. So what it did was, so this also has a valve at this green line level. So whatever excess of blood flow is coming, it will act as a gateway. It will not let the excess of blood flow to directly transmit into the SVC or the abdominal organs through the IVC valve. Okay, so patients had recovered very well. There was no ascites, no edema feet. Okay, this is another therapy which is in quite vogue now for selected patients only. Mitral clip. Okay, transcatheter edge-to-edge mitral valve repair. So as I told you, in mitral valve prolapse patients, in high-risk surgical cases, and in secondary MR, okay, you can see this third indication, secondary MR, because of cardiomyopathy or ischemic dysfunction. Okay, so this case is indicated for mitral clip repair. Okay, what we do is it is a completely a transcatheter procedure. Okay, so there are clips this which we pass through the leg through a delivery system, and this will pinch. Okay, like in simple basic layman's language kind of can I tell is वो कपड़े सुखाने का चिमटा. Okay, so this will pinch the mitral valve and it will decrease the orifice and it will prevent the leakage across this orifice, which used to remain wide open over here like this. This is how this is done in the TE guidance. Okay, so this it looks like you can see the fluoro upstairs, which is a clip which is attached, and under the eco guidance we attach. Okay, we bring both the leaflets together. Okay, so this is how it looks like. Okay. So basically, there are a lot of advanced valvular therapies which are very good with good success rates, provided they are done in selected patients, okay, and eligible candidates. We do transcatheter mitral and tricuspid valve replacement also. And as I told you, for bioprosthetic valves who have failed, okay, we do in those patients also valve-in-valve procedures, okay. So it's basically valvular heart disease is a wide spectrum of manifestation. Early intervention is recommended. Select your cases very well. Advanced burnt out cases will not have good outcomes. Advanced therapies in selected candidates should be done. Thank you.
Yes, sir. Thank you, sir, for a lovely presentation. There is one question. Lina Bhagat has asked, how do you suspect aortic regurgitation, sir?
So aortic regurgitation, the patients will have symptoms of dyspnea, as I've discussed. Will have dyspnea, palpitations because it is a regurgitant lesions. On auscultation, you will find a diastolic murmur. You will used to get used to this auscultation. If you hear a few cases of this diastolic murmur cases, they will not miss those. Okay, that will be on examination. ECG will show you LVH. 2D echo will definitely pick up all the signs of aortic regurgitation and the severity. So definitely if the patient has got dyspnea, palpitations, that will point out to a regurgitant lesion. On auscultation, you will definitely find diastolic and sometimes systolic murmur also, if the flow is very good across the aortic valve. Okay.
Okay, sir. There's no more questions, I think, except Dr. Mahmood has told you, congratulations, very well taken, sir.
Thank you so much. So basically, actually, this is a very valvular heart disease. Sometimes even the cardiologists are in dilemma. Though it
Correct.
was a bit complex topic for you all, but that's why I just briefed you regarding what can happen with this valvular pathologies and regarding your role in guiding patients for early intervention. Because sometimes if the patient's intervention gets delayed, then the outcome is not that great once we do it in the early cases. So that
Correct,
is
sir.
my message. And medical management wise, it's all diuretics.
Correct. સર તમારે કઈ પૂછવાનું જ સર?
No, you carry on.
અચ્છા. On behalf of General Practice Association and in collaboration with the Jaslok Hospital Research Center, I sincerely thank our speaker, Dr. Nilesh Jain, for
There's one question.
wonderful and enlightening session.
Yeah.
I also like to thank all our participants for joining us online and making the webinar 296 a success through our presence and with interaction. Big thanks to our organizing team, Dr. B.K. Dolakia, Dr. Bharat Bhatt, and Dr. Lina Bhagat, and the technical team, Mr. Avinash and Pranav, for seamless and coordination. Thank you once again, and we hope to meet you all in the next webinar.
Just one question which is there by Dr. Jendral regarding infective endocarditis. When will you operate for the valve? So,
Okay.
infective endocarditis, the usual dictum is if the patient is stable, operate only after 4 weeks of or 6 weeks of antibiotics, whatever the course duration is complete, or a minimum 4 weeks. Unless there is a patient having severe complications, like the patient is in heart failure, not coming out of the heart failure, okay, if the patient has developed aortic root abscess, okay, if the vegetation is very large, like fungal vegetations are like around 4 or 5 centimeters. Those cases we operate early after 2 weeks of antibiotics. Otherwise,
Okay.
always wait for antibiotic course completion, whether it is mitral or myotic, the dictum remains the same. Okay, then only operate. Otherwise, if your new valve gets operated, it will be a big mess. It will be a huge complication.
Same Dr.
Sir, in
Gentile has
pregnant-
asked whether mitral or aortic.
The principle remains the same.
Okay.
Sir, in pregnant women,
Hmm.
what precautions we have to take in mitral cases?
So previously we used to come across a lot of cases because those younger females used to have rheumatic heart disease and they used
First time they come to know during pregnancy only.
So there are various categories of valvular heart disease in pregnancy. So if there is a bicuspid aortic valve with aortic aneurysm, we have to advise to terminate pregnancy because that will be a very high risk for it can cause maternal mortality. In mild to moderate valvular cases like mild MS or moderate MS, mild MR or moderate MR, we can manage with diuretics. Okay. In severe cases, maternal mortality goes very high, and specifically if the pulmonary hypertension is severe. So these are three, four subsets that you have to advise patients to terminate pregnancy. Mild to moderate cases can be managed medically with like during the delivery time. Yes, cardiac monitoring is required regarding pulmonary edema and arrhythmias. Warfarin is contraindicated in pregnancy, then we have to manage with heparin. Okay, specifically in the first trimester. Okay, so these are all contraindications and medical management profile that you have to take care of during pregnancy for valvular heart disease patients.
Yes, sir. Dr. Prajakta, thank you, sir, for your enlightening session.
Thank you.
And
Friends,
Dr. Maniar has asked, when SpO2 reduce in valvular emergency
That means patient is going into failure.
failure?
So with the SpO2, that's why I told you that if the LV, LA pressure, pulmonary venous pressure goes high, patient will have breathless and is going into pulmonary edema. That means
Okay,
the patient is going to pulmonary edema and require ICU admission.
correct, sir.
next week,
That's all, sir. Dr. Bharat will announce the next webinar.
yeah. Next week, friends, we are meeting at 2:30 sharp. We have to listen to Dr. Natasha Tipnis. She will talk about neurological problems in diabetics. Neurological problems in diabetics by Dr. Natasha Tipnis. Next week,
Okay, sir.
13th November, 2:30 sharp.
Okay, sir. Thank you, sir. Thanks.
Okay, Nikesh bhai, thank you very much.
Thank you so much.
Yeah. Tomorrow is talking somewhere.
Yeah.
Dr. Nikesh Jain is still talking tomorrow at 3 o'clock.
Yeah,
So what
sure.
is the subject tomorrow?
So it's basically decision making in STEMI, in ST elevation myocardial infarction, whether all require stents or we can just
Yeah.
manage medical management in some cases. It's a good
Yeah.
scenario. So I think I'll tell you
Tomorrow you can attend at 3 to 4 o'clock. Yeah.
Yeah,
3
sure.
o'clock.
Yeah.
Thank you, Atul bhai. Thank you, Lina.